Bismillah ar-Rahman ar-Rahim. Thank you for joining me again. And as I promised last time, we'll talk about the target volume delineation for the nasopharynx based on the new guidelines. And as I always say, I mean, this is a kind of very primitive types of lecture that I'm trying to help my junior colleague to take steps far forward in their career of the radiation oncologist, as a radiation oncologist or clinical oncologist. So the nasopharynx, I think, is one of the really interesting part of the curriculum, and it's very common in the exam. And I think it's common in the exam because it's very complicated. Could be it's full of anatomical structures and ideas, like not ideas but clinical significance, we would say. And to start with, I think the most important thing, or to familiarize yourself with, is the anatomy first. And as I'm not a radiologist, and we'll try to to just highlight a few important points that will help us in target volume delineation as a radiation oncologist or clinical oncologist. So please refer to radiology book or anatomy atlas if you want further information. In the exam, it's very common to come in the exam, so you should familiarize yourself with it, and especially the anatomy and the types of lesions and how to delineate it, and we'll take it step by step. Starting by the anatomy, as you can see, the nasopharynx is posterior to the nose and has very special characteristics. As you can see here, the what they call it, a flower-like type of thing, or a tree type of thing, inverted tree type of how it looks like, because it's very easy to know that you are on the nasopharynx. If you are on the oral cavity, it's rounded, and it's so easy to differentiate between the nasopharynx and any other structure of the head and neck. Also, if you look at the coronal section, it's easy to see that you are just under the skull base. And I think one of the most important part, or why the nasopharynx is important as for you as a radiation oncologist, because you are the main player here. There is no surgical intervention in the majority of cases except for recurrent diseases or lymph node, as we discussed it in the previous lecture. So I think you are the main player here, and that's why it's very important for you to be aware of what's going on in the nasopharynx. So the shape of the nasopharynx is very obvious, and I think maybe let's go quickly and start with what we are seeing here. This is a pterygoid plate, and just posterior pterygoid plate, the medial pterygoid plate, you'll see the Eustachian tube opening, and here is at the cartilaginous elevation called the torus tuberis. It maintains the opening of the Eustachian tube, and this is the most important fossa of the nasopharynx, the fossa frozen molar, as you can see, like mucosal plication, or like two layers of the mucosa. And here is the commonest site of the tumor, nasopharyngeal carcinoma, as we all know of that. The tumor setting here will block the Eustachian tube opening, and that's why the patient may come with otitis media, and you can see it clearly if you see like whitening and no air cells in the mastoid air cells. This is an indication that there is an obstruction of the Eustachian tube, and some patients may come to your clinic, or the cow will go to the ENT clinic complaining of ear pain. If you refer to the lecture of ear pain in head and neck cancer, we talked about the difference between the referred pain from other tumor sites and that of the nasopharynx with obstruction of the Eustachian tube. So the shape of the nasopharynx and Eustachian tube opening, torus tuberis, fossa frozen molar are of extreme importance. Also, just beside the nasopharynx, there is what we call it the parapharyngeal space, and we talked about the parapharyngeal space several times before, because the parapharyngeal space is a potential space of spread for the nasopharyngeal carcinoma. It's easy for the nasopharynx to go outside through foramen sinus of Morgagni or defect, or through the pharyngeal wall itself, and infiltrate the parapharyngeal space. We talked about the parapharyngeal space, and we said it extends from the skull base, if you look at the coronal view, down to the hyoid bone. So the parapharyngeal space is a potential site of spread of the nasopharyngeal carcinoma. It's also important to familiarize yourself with the muscles of the around the nasopharynx. We talked about the medial pterygoid muscle. There's two muscles here just medial to the medial pterygoid, the levator palatini and the tensor palatini, and I personally feel they have an importance, and I don't know why they are not we don't talk about them quite a lot. I mean, it's very difficult to see it in the CT scan, but it is somewhere here, just medial wall to the medial pterygoid muscles, so they're sitting just in at the cursor area. But I really don't know why we don't speak a lot about them. Personally, I feel like injury of these like tiny bits of muscles can also contribute to one of the late side effects of nasopharyngeal radiotherapy. When you start to have problems with nasal regurgitation, we think it could be nerve related, but why not also related to the problem in the muscles? I don't know, but it is something that you would be aware of. I'm not sure why they don't have that importance in the radiotherapy field. Levator palatini and tensor palatini, and also I'm one of the fan that I would be very careful about the spread of the soft palate through this side of the muscles. Infiltration of the tumor on this side, you have to be careful that there may be some extension going to the soft palate, and this is a very important point, at least for me. I usually look at it and be careful on that. The lateral pterygoid muscles is very well known muscles, and now the staging is talking about extension beyond the lateral pterygoid muscle to call it T4 disease. Extension to the parotid will be T4 disease. So now I think we talked about the staging in the previous lecture. One of the most important part in the nasopharyngeal tumors is the extension to the intracranial extension of the tumor, and you should be aware of very important structures around the skull base area, because they are in direct continuity with our nasopharyngeal carcinoma, and it's easy for the nasopharynx to spread to go into the intracranial middle cranial fossa through the foramen of the skull base, mainly the foramen lacerum. To speak about the skull base foramina, we need to go to the bone window, so you cannot deal or start to familiarize yourself with the skull base foramina except after going to the bone window. So you don't try to look at the skull base foramina while you are not on the bone window. When you go to the bone window, then you can go to the skull base foramina. Let's go up and just try to review it slowly, one by one. There is no doubt that we are all aware of the optic canal, and optic canal just medial to the clinoid process. It's very rare for the cavernous sinus to go there, but for nasopharyngeal carcinoma to go there, but it's worth knowing it. Just lateral to the clinoid process, you have the superior orbital fissure, and I think the superior orbital fissure for us will be important lower down, because sometimes the tumor will go to the cavernous sinus and through the superior orbital fissure, and the orbital fissure where the third, fourth, and ophthalmic division of the fifth and abducent will go to the superior orbital fissure. So it's very important to familiarize yourself with the superior orbital fissure, and it's common also for those who are working with CNS meningiomas, where you have a meningioma sitting on the skull base, or the sphenoid air sign, or a sphenoid, the greater wing of sphenoid. But for us, for the nasopharynx, I think the most important part will be the lower part, as well as the cavernous sinus. I think the cavernous sinus, you need to change it again to the brain window, but I will not go that, because it's easy to know the cavernous sinus. Cavernous sinus is structure just lateral to the cell letters. So if you look at the coronal view, for example, just lateral to the cell. This will be around the area of the cavernous sinus. And the cavernous sinus, it's called cavernous because it's contains septi, like divided into caves, and that's why like fibrous. It's not like the other sinuses, by the way. It's divided into small caves or small sinuses, and that's why we call it cavernous sinuses. And it spans from the orbital apex to the apex of the petrous bone, and this is important. So tumor setting or going intracranial can easily go to the cavernous sinus and hit the abducent third, fourth, and maxillary division of the fifth. And that's why I do believe that for any exam question, if you have a nasopharyngeal carcinoma and you didn't say or examine, if it's face to face, and you didn't say in the exam that you will have to examine all cranial nerves, I think you should fail, because it's easy for nasopharyngeal carcinoma to go intracranial to the middle cranial fossa. So you have to thoroughly examine the patient, and also very small information from the patient can guide you perineural invasion or intracranial extension. If you have a patient who's saying I have double vision, that is recently, I didn't have it before, this is very important. So you have to know that the cavernous sinus can be infiltrated. And now is the new guidelines, I think they emphasized on the importance of the cavernous sinus more than previously. So this time they are talking about the inclusion of the ipsilateral cavernous sinus, whether prophylactically or if there is infiltration, you will have to include it in the post-induction chemo, or if there is post-induction chemo gross disease, you will have to include it anyway. There is now also important point in the new guidelines. It says that if the tumor was pushing the brain, you can, after the induction chemotherapy, if there is improvement of the tumor, you can shave the brain off your target, except if it is infiltration. Yeah, maybe it's worth mentioning it, but yeah. But it is important to be aware of the cavernous sinus, orbit to apex, orbital apex to petrous bone apex. This is extension of the cavernous sinus. And if there is extension of the tumor of the cavernous sinus, you may need to take what we call it the Meckel's cave, as well as the trigeminal nerve. I can go through it again while having target volume delineation, but for the time being, it's just for your information. Meckel's cave and the trigeminal nerve may be needed. You may need to extend your volume to it. Pituitary gland is sitting in the pituitary fossa, and I think that it's very important for any patient where the pituitary gland is irradiated that the GP or endocrinologist will follow the patient for pituitary function test on the long term, because sometimes you may have a decline of the pituitary function, and one of the most important things that I usually see is impotence, by the way, and LH and testosterone level can be important for our patients, especially the young age ones. Anterior clinoid, posterior clinoid, it's easy to know, and then you will have what we call it the clivus. So the clivus is a key bone in the nasopharynx. So you can see it here in the sagittal view. As you can see, this is the clivus, but on the posterior clinoid, and it is triangular shaped, and it's forming the skull base. It's easy for the tumor to infiltrate the clivus. Why it's easy for the tumor to infiltrate the clivus? Because the clivus is one of the porous bones. So the bone that is not, it's what we call a spongy bone. I can't remember the name, but it's porous and easy to be infiltrated. So the clivus is very important point for us. Another important bone for us is the vomer, and the vomer is also considered part of the roof of the nasopharynx. So this triangular bone is the vomer, and this should be covered properly in any nasopharyngeal carcinoma. The clivus is a key point for us, so familiarize yourself with how it looks like, because I will build a lot of information on it very soon. And the first information, that on the lateral side of the clivus you will have this large foramina. It's called the foramen lacerum, and we are aware that the foramen lacerum is a weak point in the skull base. It's easy for the tumor to infiltrate the foramen lacerum. If you put your cursor on this tumor, let's say there is a tumor in the fossa of Rosenmuller here, and I'm going up through the nasopharynx. As you can see that it will guide you to the foramen lacerum. So foramen lacerum on the lateral side of the clivus, easy for the tumor to infiltrate the cavernous the foramen lacerum, as whenever it goes to the foramen lacerum, find itself on the lateral side, middle cranial fossa, and the tumor will find itself close to the cavernous sinus. So the foramen lacerum is a potential site of spread, and you may need to cover it properly with nasopharyngeal carcinoma. The cavernous sinus, the foramen lacerum, as you can see, it's a very large foramina. You cannot miss it. And if you look at it from the side, you'll see as if it's a drumstick shape appearance, like it ends in the foramen lacerum here, but this is the carotid canal. Why it's important, the carotid canal? Because it will guide us to the next foramina just anterior and lateral to it, which is the foramen ovale. Foramen ovale is just anterior and lateral to the cavernous, to the foramen lacerum and carotid canal. So now what we did is we looked at a key bone called the clivus, and it's easy to know where is the clivus. We looked at either side of the clivus. We found a foramen called foramen lacerum, and this foramen lacerum should be covered for nasopharyngeal carcinoma. It's a potential area for spread. Drum-like shape, carotid canal anterior and lateral to it is the foramen ovale. The foramen ovale is also a potential site of spread, and in the new guidelines would say you would need to cover the ipsilateral side. At least in the past, we used to treat both sides, and we treat or the whole skull base, but nowadays we say the guidelines would say if it's a very, very well localized tumor to one side, you can spare the contralateral foramen ovale, which can help to reduce the volume of your to help reducing the volume for your target volume. More posterior to the foramen ovale, the foramen spinosum. Maybe it's not very obvious here, but it's not of value. Meningeal artery will pass that, but it's not of value for us in radiation oncology. More importantly, I think there is another two foramina. One is called the Vidian canal. Vidian canal is sometimes we miss it, or we sometimes we miss it as if it's a foramen rotundum. So the Vidian canal is a very important part of the story, and the Vidian canal is it join the Pterygopalatine fossa. We'll come to it now. To Pterygopalatine fossa to the foramen lacerum. It's a canal that where is the Vidian nerve will be sitting, and it is a easy connection from Pterygopalatine fossa posteriorly to the foramen lacerum. So if the Pterygopalatine fossa is affected, the Vidian nerve canal or Vidian canal should be covered properly. The Pterygopalatine fossa is one of the most important fossa in the head and neck, and I called it before in a previous lecture, I called it the roundabout of the head and neck, or you also can that all opening end in the Pterygopalatine fossa. The Pterygopalatine fossa is very crucial. It is the site where the maxillary nerve is affected, is located, is sitting there. The ganglia is sitting there, and it is connected to almost maybe 7 pathways and easy to be missed during a nasopharyngeal carcinoma tumor if it is infiltrated. So as you can see, the nasopharynx, anterior to the nasopharynx will be the nose, and the nose will open the choana. So this is what we call it, the anterior border of the nasopharynx. And here is the pterygopalatine fossa. The pterygopalatine fossa is just posterior to the maxillary sinus and anterior to the pterygoid plate. So it's basically formed by the pterygoid plate and the posterior wall of the maxillary sinus. And this is a very important part of the target volume delineation, and you will read a lot about it. If we look at where the pterygopalatine fossa open, it can open in the nose. So we can see this, it open in the nose through the what we call the sphenopalatine opening. So the tumor setting there can easily go to the nose. And that's why when the nasopharynx with target volume delineation, we say extend. If you remember, in the old days, we used to say take 1/3 of the maxillary sinus. Actually, it's not to cover the maxillary sinus itself, but it's cover the pterygopalatine fossa and its opening into the nose. There is also what we call it the pterygomaxillary fissure. It's the opening of the pterygopalatine fossa in the infratemporal fossa. So in short, the horizontal spread nose sphenopalatine opening, infratemporal fossa through the pterygomaxillary fissure, but it's not the whole story. It can open anteriorly. It can go to the inferior orbital fissure. Look at this. So this is the pterygopalatine fossa. It can open to the inferior orbital fissure and go to the orbit. And we know now that inferior orbital fissure infiltration is a T4 disease, so it easily can go to from the pterygopalatine fossa to the orbit. So the infratemporal fissure can be affected. Not only that, the pterygopalatine fossa open posteriorly through the foramen rotundum. Here you can see it's actually a canal. The foramen rotundum is a canal. You can easily see it in the coronal view, just lateral to the sphenoid, or if you just put your cursor on the pterygopalatine fossa and go up, you'll see an opening into the middle cranial fossa, and this is foramen rotundum. Foramen rotundum is where the maxillary nerve pass, by the way, go in through the foramen rotundum. So the foramen rotundum, so pterygopalatine fossa, sphenopalatine opening, pterygomaxillary fissure, inferior orbital fissure, and anteriorly inferior orbital fissure, and posteriorly foramen rotundum. Don't forget horizontal spread, anterior spread, posterior spread. This all can happen with just tumor setting into the pterygopalatine fossa. But is it only like that? No. It's not only like that. You can see that the pterygopalatine fossa, if you go down, we can direct you to the oral cavity. Imagine that through the greater palatine foramina. So the greater palatine foramina and lesser palatine foramina. To the tumor from the nasopharynx to, up. So pterygopalatine foramina, tumor to the nasopharynx, you may need to cover part of the greater palatine foramina and lesser palatine foramina if you have a tumor that is extending through the maxillary nerve. So it's very important to be aware that perineural invasion in the nasopharyngeal carcinoma is common. It happens, and it is easy for the tumor to spread through the pterygopalatine fossa, and pterygopalatine fossa is the key point in our nasopharyngeal carcinoma. So please make sure it is covered properly, especially if the tumor is setting there. And sometimes you may see some infiltration, like widening of the canal compared to the other side, and this can be also an indication of the pterygopalatine fossa and maxillary nerve infiltration. So the pterygopalatine fossa is a key point for you in nasopharyngeal carcinoma, and you need to familiarize yourself with it. If you look at the sagittal view, look at this fossa here, going to the orbit, going down, to the oral cavity. So it's a key point. If you don't cover this region properly, this will be a problem, and your patient may be in problem. So nasopharynx. So what we said so far, we said that nasopharynx has like an inherent relationship to the skull base, and we started by a porous bone called the clivus. Foramen lacerum. Foramen lacerum guided us, the carotid canal guided us to the foramen oval. The foramen lacerum as well, a canal connecting the foramen lacerum to the pterygopalatine fossa called the Vidian canal. The pterygopalatine fossa open to the Nasopharynx foramina, open to the infratemporal fossa through the pterygomaxillary fissure, open up to the, or anterior to, up and anterior, you can say, to the inferior orbital fissure toward the orbit, posteriorly to the, through foramen rotundum to the middle cranial fossa, maxillary nerve entering through the maxillary foramen rotundum here. In the coronal view, it is nice to look at the coronal view because foramen ovale and foramen rotundum are not the same. So you can see just lateral to the sphenoid sinus foramen rotundum. But if you look at the foramen ovale, it's the largest opening in the skull base. Look at this. This is the foramen ovale. So you can never miss the foramen ovale in your target volume delineation, actually. So you need to make sure that if the tumor is sitting somewhere here, that all this is covered properly, and whether you cover it with the mid CTV or the low dose CTV, but it is important to cover it properly to the in nasopharyngeal carcinoma. Maybe the last thing that I would like to talk about is the jugular foramina. But the jugular foramina is easy because you can just follow the jugular vein up, where the jugular vein, where the sigmoid sinus become jugular vein. This would be the jugular foramina. Maybe it is worth mentioning here that in level 7A is in the nasopharynx specifically will reach the jugular foramina. So if you revise the guidelines for Gregoire and the Hanka group, when we talked about the anatomy of where 7A should stop, we said about the upper border of C1, if I remember correctly. But now we are talking in the nasopharynx that the 7A should extend to the jugular foramina, very, very similar to 7B. So 7A and 7B level of lymph node will end at the same level at the jugular foramina at the skull base. So this is an important difference between 7A, the usual 7A in the other tumor site in the head and neck, and 7A for the nasopharynx will be different. The last thing I think you need to familiarize yourself with is the hypoglossal canal. And the hypoglossal canal is important for any tumor infiltrating the clivus. That's very important. And also it is important to for any patient, because of if there is a hot spot in the hypoglossal canal, you may cause injury of the hypoglossal nerve and may end up by paralysis, and we see it. So we see some patients that will come after maybe 10-12 years of successful treatment in radiotherapy, and they will start to have some problems in speaking. And when you do MRI and you do investigation, you cannot see any recurrence of the tumor, but it is clearly there is a hypoglossal nerve paralysis. So it is important to delineate the hypoglossal nerve, and the easiest way is to go downward to the what we call it the condyles of the skull base, foramen magnum. If you go to the condyles and go up, then you will see the hypoglossal canal opening on either side, and you just draw the nerve, and we can do that when we start to draw our target volume. I think I need to stop here because it'll be confusing. And when we talk together about the target volume delineation based on the um, based on the new guidelines, I think we can also emphasize on each structure on its own again and again, so that you get used to it.